I'm Dr. Wilbert S. Aronow, Professor of Medicine at New York Medical College in Valhalla, New York. I gave a presentation at the annual scientific sessions of the International Academy of Cardiology 21st World Congress on Heart Disease, which was held in Boston, Massachusetts. The topic of my presentation was titled 2016 Update Treatment of Hypertension. The SPRINT trial randomized 9,361 persons aged 50 years and older, mean age 67.9 years, with a systolic blood pressure between 130 to 180 millimeters of mercury at increased cardiovascular risk, but without diabetes mellitus, heart failure within the past 6 months, a left ventricular ejection fraction below 35%, prior stroke, or an estimated glomerular filtration rate less than 20 milliliters per minute, to a systolic blood pressure goal of less than 120 millimeters of mercury versus less than 140 millimeters of mercury. The primary outcome was myocardial infarction, other acute coronary syndrome, stroke, heart failure, and cardiovascular death. The median follow-up was 3.26 years. Compared to a systolic blood pressure goal of less than 140 millimeters of mercury, a systolic blood pressure goal of less than 120 millimeters of mercury significantly reduced the primary outcome by 25%, all-cause mortality by 27%, heart failure by 38%, and cardiovascular death by 43%. The lower systolic blood pressure goal also significantly reduced the primary outcome by 33% in patients aged 75 years and older versus 20% in patients aged 50 to 74 years of age. On the basis of these data, patients who were enrolled in the SPRINT trial, these patients should be treated to a systolic blood pressure goal of less than 120 millimeters of mercury with intensive monitoring for adverse events. On the basis of the available clinical data, I would treat patients who have diabetes mellitus or heart failure with either a reduced ejection fraction or a preserved ejection fraction, patients with a left ventricular ejection fraction less than 35%, patients with a prior stroke, and patients with an estimated glomerular filtration rate less than 20 millimeters per minute with a blood pressure goal of less than 130 over 80 millimeters of mercury. I would treat patients with an acute coronary syndrome to a blood pressure goal of less than 140 over 90 millimeters of mercury. The Canadian 2016 hypertension treatment recommends treating patients to a systolic blood pressure goal of less than 120 millimeters of mercury if they have clinical or subclinical cardiovascular disease, if they have chronic kidney disease, if they have an estimated 10-year global cardiovascular risk of 10% or higher, or if they are aged 75 years and older. Blood pressure must be measured in the standing position as well as in the sitting position to detect orthostatic hypotension caused by antihypertensive drug therapy. The standing systolic blood pressure should not be less than 110 millimeters of mercury, and intensive blood pressure monitoring should be guided by automated office blood pressure measurements. Hypertension must be treated with lifestyle measures. Patients with primary hypertension may be treated with either an ACE inhibitor or an angiotensin receptor blocker or a calcium channel blocker, or a thiazide or thiazide-like diuretic, or a beta blocker. The choice of antihypertensive drug therapy in patients with comorbidities depends on the comorbidities. For example, patients with ischemic heart disease should be treated with a beta blocker plus either an ACE inhibitor or an angiotensin receptor blocker. If a third antihypertensive drug is needed, either a thiazide or thiazide-like diuretic or a calcium channel blocker may be used. Patients with heart failure should be treated with a diuretic plus an ACE inhibitor or angiotensin receptor blocker, plus a beta blocker, and plus an aldosterone antagonist if indicated. Patients with chronic kidney disease should be treated with an ACE inhibitor or an angiotensin receptor blocker. Patients with osteoporosis should be treated with a thiazide or thiazide-like diuretic. If a patient has resistant hypertension, despite lifestyle measures and optimal doses of 3 antihypertensive drugs, including a thiazide or thiazide-type diuretic, then the 4th antihypertensive drug of choice should be an aldosterone antagonist. A major contributor to resistant hypertension is that patients fail to take their medication.